I'm Dr. Matthew Herring, an orthopedic traumatologist currently working in Redding, California at Epic Orthopedics. So we're going to do the placement of the tension band for a medial malleolus fracture. Begin first with a direct medial approach to the medial malleolus. This is incising skin and carrying the dissection sharply. You'll want to identify the saphenous vein and retract that safely. Posteriorly, you could run into the posterior tibialis tendon, so being aware of that as well. So once your exposure is done, then you proceed to your reduction and fixation of the fracture. You can temporize it with instrumentation in the tray, such as the lobster claw or the point-to-point reductor clamps and multiple K-wires. We'll proceed to placing K-wires for the cannulated screws first. All right, so placing the first K-wire and the second K-wire. So when putting these K-wires in, what I would do is aim them to be slightly divergent so that your shaft screw can go between the two cannulated screws. So you can see these are aimed slightly divergent pattern. At this juncture, what we would do is get C-arm fluoroscopy imaging to ensure the appropriate K-wire length and trajectory. And then once that's confirmed, we can measure using the depth gauge. This one measures a 36, and this one measures a 32. So during the drilling process, you can just pop the neocortex, or you can drill the entire length of the screw, depending on surgeon preference. At this juncture, what we'll do is we'll first apply our tension band plate over the K-wires. So I use a power driver to set the screws the majority of the way, and then we will final tighten on hand. And then we'll switch to the hand driver. And I would tighten the medial malleolar screws to your usual standard, which for me is 2-finger tight. Alrighty, the final step now is to apply the shaft hole through the plate. This tensions the construct and finalizes the fixation. So next what you want to do is push the plate down to the bone using your thumb, and then you want to drill your shaft screw, and I drill eccentrically for compression mode. And again, what you'll want to be doing is aiming for between the two screws that you previously placed. And then you will measure your depth. Which we have a 46. This screw should be drilled for bicortically, for bicortical purchase. Okay, and then the K-wires are removed. And the shaft should be a non-locking screw, again, to lag the plate down to bone and compress the arms. If additional fixation is required, the more proximal screw hole will accept both locking and non-locking screws. The holes on the plate arms to accept only the 4.0 millimeter cannulated screws. As you can see, the plate contoured very nicely to the medial malleolus once you place the non-locking screw. The implant itself is designed to contour to the medial aspect of the tibia using this technique alone. Pre-bending or pre-contouring these arms is not necessary or recommended. The idea behind this implant is to create a tension band construct, which we believe provides increased fracture stability through construct strength compared to using cannulated, partially threaded screws alone. So this completes the placement of the construct. At this point in time, I would obtain multiple serum fluoroscopy views, which include AP, mortise, and lateral views to ensure the appropriate implant position, screw length, and maintenance of the reduction.